when we talk about torn menisci, I think it's important for people to know that the meniscus naturally degenerates a little bit with age. And so you're not supposed to have a completely normal MRI at age 40 or 50. You may have some degenerative signal or a little minor tearing in the meniscus. And I kind of jokingly say you treat the patient, not the MRI. And so people get a report and they read what the radiologist thinks about their MRI, and then it kind of freaks them out because they may get 4 or 5 different things that are wrong with their knee. Well, these are minor little things often that are maybe other than completely normal, but that doesn't mean it's a problem that needs surgery. So I think with meniscus tears, some are degenerative and just need conservative treatment. Some, even in young people, are little horizontal splits within the meniscus. That meniscus is sitting in your knee like a cup-shaped washer. It's a gristly cushion in your knee, and the cartilage surfaces do kiss in the middle, but the meniscus is kind of filling up that dead space because the meniscus, the surfaces kind of go together like this. They're not really conforming and completely uniform. So that meniscus is a cushion that's filling that gap. Well, sometimes it splits, and it still acts like a washer, maybe 2 washers stacked on top of each other. It can still do its job. Other times it tears and is unstable. So the main indications for surgery for a meniscus would be something unstable that's mechanically popping, going out of place, your knee gets stuck, failure of conservative treatment. If you're my age, and you don't have an unstable meniscus, well, you may go on for a while and it just doesn't get better with anti-inflammatory medicines, maybe a shot, maybe some therapy, stall a little bit and see if it settles down. And then if it doesn't, you may need surgery. Young kids that have a meniscus tear, a little bit different category. Often those are repairable. They have good blood supply in the meniscus and you can suture those. So if you have a meniscus tear that's all by itself, sometimes you trim it, sometimes you suture it, and that depends on what kind of pattern of tear you have. It can also depend on what it looks like when you get in there. There's a difference between what the MRI shows versus what you see when you get in there, and I think patients don't fully understand that. The radiologist is not seeing what the surgeon would see looking, but the advantage is that the MRI is not invasive. So the analogy that I give patients is it's kind of like looking at the Titanic with sonar from the surface. You see it, but you don't see it quite as well as you do when you go down and turn the lights on and with scuba gear. So when you scope the knee, it's invasive. You got to go down there, but it's very, very, very accurate. So usually the final determination of the way a meniscus is treated is when you look right at it, and the surgeon makes the decision kind of with a mutual agreement of what the plan is with the patient.